Hello everyone, welcome back to my baby YouTube channel. This video is all about acute pancreatitis. We'll cover this topic in detail. So let's get started. First of all, anatomy of pancreas. We know the pancreas consists of head, neck, body and tail. Then So in the second picture, it is a transverse section of the pancreas. So we can see the position of uncinate process and behind the vessels, like superior mesenteric vein and superior mesenteric artery. And the first figure, it is a posterior relation of the pancreas. So our topic is acute pancreatitis. So the definition of acute pancreatitis, it is defined as an acute condition presenting with abdominal pain, a threefold or greater rise in the serum levels of the pancreatic enzymes, which is serum amylase or lipase, and also characteristic finding of pancreatic inflammation on CECT, contrast enhanced CT. And acute pancreatitis can recur as well. So the underlying mechanism of injury in pancreatitis is thought to be because of the premature activation of the pancreatic enzymes within the pancreas, which is leading to the process of autodigestion. So anything that injures the acinar cell and impairs the secretion of zymogen granules or damages the duct epithelium and thus delays enzymatic secretion can trigger this acute pancreatitis. Once cellular injury has been initiated, the inflammatory process can then lead to pancreatic edema, hemorrhage, and eventually the necrosis of the pancreas. And as inflammatory mediators are released into the circulation, there can be systematic complications as can also arise. So basically, we know that pancreas consists of enzymes, but in pancreas, those are inactivated enzymes. They are not activated. Once those enzymes reach the duodenum, because of the alkaline nature in duodenum, those enzymes get activated and helps in the digestion process. But here in pancreatitis, what is happening is those enzymes in the pancreas are getting activated inside the pancreatic parenchyma itself, and thereby it is causing the digestion of the pancreatic parenchyma and causing the inflammation of pancreas. So that is the mechanism. So let's look into the causes of acute pancreatitis. And the most common cause of acute pancreatitis, it is contrary to the popular belief that alcohol is a main reason. The most common reason is not alcohol, whereas the most common cause of acute pancreatitis is gallstone induced pancreatitis, and the alcohol is a second most common cause, and in most common cause in children is a trauma of the pancreas. And there can be iatrogenic causes, like after post ERCP can cause pancreatitis, and also drug induced pancreatitis, and drugs such as thiazide diuretics, ARTs, antiretroviral therapies, chemotherapy drugs, also azathioprine, and hyperparathyroidism can also be a reason for pancreatitis. Increased triglyceride levels in the blood, a condition called pancreas divisum. It means the ventral and the dorsal bud of the pancreas is not fusing, so they are separately opening, and this condition can cause higher chances for pancreatitis. The reason can be idiopathic, and also scorpion bite can be a cause of pancreatitis. So here there is most common causes and some uncommon causes of pancreatitis. So the most common cause, which is gallstone, and the second most common cause, and the most common cause in children, which is trauma, is being asked in various exams. So after the causes of acute pancreatitis, these are the clinical features in acute pancreatitis. So acute pancreatitis are more common in males as compared to females, and the patient will comes with epigastric pain which a patient will say that the pain is radiating to back and it is relieved by bending forward, and also comes with nausea and vomiting. And if we look into the signs of acute pancreatitis, acute pancreatitis is being said uh, a condition where the symptoms are more severe, and signs comes like in the later stages. For example, in case of mild and moderate cases, we don't get any signs, or only signs are visible in the severe acute pancreatitis, over there is hemorrhagic acute pancreatitis. So signs in case of severe acute, that is hemorrhagic pancreatitis, because of the bleeding into the facial planes, can produce this bluish discoloration over the skin. So there are various signs. Cullen sign, where discoloration is around the umbilicus, and there is gray Turner sign, where the discoloration in the flank region, Fox sign when there is discoloration in the inguinal region, and the Bryan sign when the discoloration in the scrotum. So in figure we can see the Fox sign, which is the discoloration in inguinal region. And for easy to memorize, we can remember like this, like Cullen sign, C for central, so umbilicus is the central, so Cullen signs is the discoloration around the umbilicus. And here in A figure, it is Cullen sign, which is discoloration around the umbilicus, and B is green Turner sign, which is around the flanks. So we have look into the causes, signs and symptoms. And now if a patient is coming to emergency department and it is suspected to be a case of acute pancreatitis, so the investigation, what are the investigations which we need to do? So the first investigation for a suspected case of acute pancreatitis will be drawing blood to check the levels of pancreatic enzymes, which is serum amylase and serum lipase. So if we asked like just one enzyme, it will be serum amylase. So if we talk about serum amylase, it is sensitive, but it is not so specific. So it means that there will be increased serum amylase in other conditions as well. In case of acute pancreatitis, of course, it will be increased serum amylase, and it is said like it will be increased like 4 times the normal value. But serum amylase can also be increased in other conditions like mesenteric ischemia, bowel perforations, volvulus, and torsion. Whereas if we talk about serum lipase, these enzymes rise late, but it is more sensitive and more specific. But the important thing to note here is that serum amylase and serum lipase values will not be a predictive for the severity of the attack. By looking into the values of these enzymes, we cannot understand how severe the acute pancreatitis it is. We cannot say that. So under investigation after the enzyme levels, there are some, if we take into the x-rays, we can see some non-specific signs in the x-ray. So the first figure is corresponding to sentinel loop, which is a focal dilated proximal jejunal loop in the left upper quadrant, and there is colon cutoff sign in the splenic flexure and the transverse colon region, and also the gaseous abdomen. So these can be questions asked, like what are the x-ray findings in acute pancreatitis. Mainly we have the signs because of acute pancreatitis inflammation, there is ileus, so bowel is not contracting, and because of that we can have such signs in x-ray. And also the investigation of choice, if we get a question like what is the investigation of choice in acute pancreatitis, it will be CECT. And ideally it is said that CECT should be done after 72 hours, because if we do the CECT after 72 hours, it can give a correct amount of necrosis. Otherwise, if we done before 72 hours, it can underestimate the amount of necrosis. ideally speaking, this CECT should be done like on a serial manner, like during the admission, after 24 hours, after 48 hours, after 72 hours. Then we get a correct understanding about the amount of necrosis. So in patients with pancreatitis, necrotic areas within the gland can be identified by the absence of contrast enhancement on the CT. So those necrotic areas, there will be absence of contrast enhancement on CECT. So inflammatory collection and pseudocyst can also be visible if we do a CECT. And the CT guided drainage is helpful in the treatment of pancreatic collection, cyst and pseudocyst, and facilitates percutaneous fine needle or truncated biopsy. So in figure we can see the CT scan of a large pseudocyst in relation to the body and tail of the pancreas. So after the investigation, we have diagnosed the condition as a case of acute pancreatitis. So after we get a diagnosis, what we need to know is the severity of the attack. So how severe is the condition? So in order to understand the severity, we have got various classifications. So there is Glasgow criteria, and under Glasgow criteria, like a value of 3 or more than 3 correspond to severe pancreatitis. And there is Ranson criteria, and this slide corresponds to Ranson criteria. So Ranson criteria will be different for alcohol, and also it will be different for gallstone, and it is done on admission. There are some criterias, and also within 48 hours of admission there are some criterias, and each is given 1 point each. So like if the score comes less than 3, there is 0 to 3% mortality, and if it is scored 3 to 5, there is 11 to 15% mortality, and it's scored more than or equal to 6 correspond to 40% mortality, and the score of 3 or more than 3 corresponds to severe pancreatitis. So it is an important criteria, and questions are usually asked, so it is important to memorize the Ranson's criteria. And there is also another score which is BISAP score. So B stands for blood urea nitrogen more than 25 milligram per deciliter, I for impaired mental status, S for SIRS, and A for age more than 60, and P for pleural effusions. So we have the scores and the mortality rate corresponding, and also here also a score of 3 or more than 3 correspond to severe pancreatitis. And there are also other methods of assessment of the severity of the condition. We can check the values of C-reactive protein value, and if it comes like more than 150 international unit per liter, it corresponds to severe cases. Then there is Apache score, which is acute physiology and chronic health evaluation score, and value of 8 or more than 8 is severe. And this score of 8 or more than 8, that was a previous question. And there is a score, Apache score specific for acute pancreatitis, which is Apache O. O correspond to or stands for obesity. So like in obese patients, this acute pancreatitis can be a poor prognostic feature. And there is SAP score, which is simplified acute pancreatitis score, HAP score, which is harmless acute pancreatitis score, and there is this modified Marshall score, and the value of 2 or more than 2 denotes an organ dysfunction. So in order to check for organ dysfunction, we use this score, which is modified Marshall score. And the very important or the best score in acute pancreatitis is the Balthazar's grade, which is also called CT severity index, and this, as I said, is the best score, and a value of 6 or more than 6 is corresponding to severe pancreatitis. So as like normal pancreas is given the value 0, and if there is focal or diffuse enlargement, it is given 1 point. If there is peripancreatic inflammation, 2 points. A single fluid collection, 3 points. 2 or more collection, 4 points. And there is Atlanta classification in case of acute pancreatitis. So, so under Atlanta classification, it can be divided like mild, moderate, and severe cases of acute pancreatitis based on two things like local complication and organ dysfunction. If both are absent, and it is a mild pancreatitis. If there is only local complication and the organ dysfunction is just transient, like in less than 48 hours, it is a moderate case. And if local complication is present as well as organ dysfunction is present even after 48 hours, then it corresponds to severe pancreatitis. So under Atlanta classification, we have got four definitions. So it is acute peripancreatic collection, acute necrotic collection, pseudocyst, and vault of necrosis. We need to know about each of this. So in order to understand, or in order to memorize it better, I would say that if there is a word like acute, it means it will be less than 4 weeks. And because it is an acute case, the wall will not be fully defined. And if it is said like there is necrotic in the word, and it means that the collection will be heterogeneous collection. So let's look into each of this. So acute peripancreatic collection. So the word acute, so it will be less than 4 weeks, and it will be, there is no necrosis, so it will be homogeneous fluid density, and it will be adjacent to the pancreas, peripancreatic. Okay. In case of acute necrotic collection, acute, so it will be less than 4 weeks. The wall will not be fully defined, but necrotic, so there will be heterogeneous collection, and it can be either intra or extra pancreatic. Then there comes a pseudocyst. So it will be there is no acute word, so it's more than 4 weeks, and it will be homogeneous fluid density, and the wall will be well defined wall. And in vault of necrosis also more than 4 weeks, and because of not acute, it will be well defined wall, and there will be necrosis, so there will be heterogeneous collection. So these are the figures. In figure 1 we can see this CT scan showing acute necrotizing pancreatitis. So we can see the area of reduced enhancement in the pancreas, and the peripancreatic edema, and the stranding of fatty tissues. And in figure second one, we can see the infected pancreatic necrosis in an elderly patient. So we can see the reduced enhancement in the pancreas and the peripancreatic fluid collection with pockets of gas. So this is resolved after percutaneous drainage and antibiotic therapy. So we'll come into the management of this condition. So now the management of acute pancreatitis. First of all, the patient is made nil per oral, IV fluids are given, and analgesics also given to the patient. We avoid the opioids like morphine, and IV antibiotics are not given in case of mild or moderate cases. We only use IV antibiotics if there is necrosis and if the infection is documented. So like in severe cases, so antibiotic of choice will be meropenem. And it is said that early initiation of enteral nutrition, like if the patient can take the food by oral, if that can be given, or else nasojejunal route or nasogastric route, we should early initiate the enteral nutrition. Nasojejunal route will be preferred than nasogastric route, because by that we can bypass the area of inflammation or area of ileus. And so this early initiation of enteral nutrition is found to reduce the mortality rate in acute pancreatitis. And in case of gallstone pancreatitis, as I said, gallstone is the most common reason. So if patients has severe jaundice which is not resolving, and symptoms more than 48 hours, then we have to go for ERCP with sphincterotomy. And with patients with gallstone pancreatitis should always undergo cholecystectomy before the patient is being discharged from the hospital. So after the management, some of the complication of acute pancreatitis the in acute pancreatitis there is local complication as well as systemic complications. So in case of local complication, as I said from the Atlantic classification, those four definitions like acute peripancreatic collection, acute necrotic collection, pseudocyst, wall of necrosis. So acute peripancreatic collection can be managed by an external drainage with the pigtail catheter. Acute necrotic collection also by the external drainage or like surgical necrosectomy, like surgically removing the necrosis area. So and after this we have to give we can use a Beggar's technique. For continuous lavage, and but this acute necrotic collection and this surgical necrosectomy are related to very high mortality rate. And in case of wall of necrosis also we can go for external drainage. Splenic vein thrombosis is one of the local complication in acute pancreatitis, and it can lead to left-sided portal hypertension. Then we have to go for splenectomy. Then there is splenic artery pseudoaneurysm, and splenic artery is the most common vessel involved. So CT angiography or MR angiography helps to make the diagnosis of the splenic artery pseudoaneurysm. Treatment will be embolization or surgery, and this splenic artery is the most common visceral artery aneurysm as well, and there is also pleural effusion on the left side. So in this slide it is a detailed mentioning of the procedure of pancreatic necrosectomy. So the surgical approach may be through a midline laparotomy, especially if the area involved is around the head of the gland. The duodenocolic and gastrocolic ligaments should be divided and the lesser sac opened. Through debridement of the dead tissue around the pancreas should be carried out. And if the body and tail of the gland are primarily involved, a retroperitoneal approach through a left flank incision may be more appropriate. The tissues are inevitably friable, and one should be careful not to precipitate excessive bleeding or inadvertently breach the bowel wall. Blunt dissection is preferable to sharp dissection. A feeding jejunostomy may be a useful adjunct to the procedure. If gallstones are precipitating factor of the pancreatitis, a cholecystectomy should be included. And some prefer a minimally invasive approach to a formal laparotomy. A rigid laparoscope is inserted into the peripancreatic area through a retroperitoneal approach, and vigorous irrigation and suction is combined with a gradual nibbling away of the necrotic debris. So here it's mentioning how the procedure of pancreatic necrosectomy is carried out. So in first figure, we can see the necrotic body and the tail of the pancreas removed as an intact specimen rather than piecemeal. The patient had suffered severe necrotizing gallstone pancreatitis complicated by persistent pancreatic sepsis. Necrosectomy was carried out through a left flank retroperitoneal approach. And this is a Beggar's technique which I was talking about, which we do after the surgical necrosectomy. So basically, two drains are left in the row area fleshed. So there are two tube drains, and through one drain we irrigate, and through the other drain we flush out. Then we use the other drain to irrigate. Then through the next drain the fluid comes out. So continuous post-operative closed lavage of the lesser sac as advised by Beggar. Lavage is carried out through several double lumen and single lumen catheters. Each time 1 liter of saline is infused through and then drained over a period of hours, and the process is repeated. So this is Beggar's technique. So as I said, there are local complication and systemic complication. Previously we saw this local complication. Some of the systemic complication is SIRS, which is systemic inflammatory response syndrome, is defined by the presence of two or more of the following criteria. If the heart rate is more than 90 per minute, core temperature is less than 36 degrees Celsius, or it can be more than 38 degrees Celsius, respiratory rate is more than 20 per minute, or partial pressure of carbon dioxide is less than 32 millimeter mercury, and the white blood cell count less than 4,000 or more than 12,000 per millimeter cube. So if we define as if the presence of two or more of the following criteria, and also sepsis is a systemic complication, shock, ARDS, acute respiratory distress syndrome, CHF, and MODS. And pseudocyst is one of the local complication. So in pseudocyst, basically there is collection of amylase rich fluid lined by a granulation tissue. So as the name suggests, pseudocyst, it is a false cyst. So it is not lined by epithelium, it is lined by granulation tissue. And if we say pseudocyst is more common in acute or chronic pancreatitis, it is more common in chronic pancreatitis rather than acute pancreatitis. And the most common site of pseudocyst is a lesser sac, but it should be noted that it can be seen anywhere in abdomen. So in case of pseudocyst, we have a classification called D-Egidio classification. So basically in D-Egidio classification, there are like 1, 2, and 3. The first type correspond to pseudocyst happening in acute pancreatitis, and there is no communication with the main pancreatic duct. In second, it can be in acute on chronic pancreatitis, and there can be or cannot be, may or may not have communication with the main pancreatic duct. And third, classification for the chronic pancreatitis and usually have communication. So the clinical features of pseudocyst is the patient will come with epigastric pain. So basically in lesser sac, which is behind the stomach, there is fluid filled, so it will be pushing the stomach to the anterior abdominal wall, causing the epigastric pain, feeling of fullness, and nausea and vomiting. So in case of investigation of choice, as in case of acute pancreatitis, in case of pseudocyst, the investigation of choice will be CECT, and the management of pseudocyst, in majority of pseudocyst, can resolve spontaneously, so we do not have to do anything. But there are some indications for the intervention in case of pseudocyst. If the cyst is more than 6 weeks old, if it is more than 6 centimeter in size, and the wall thickness of the cyst is more than 6 millimeter, then these are the indication for intervention. And some of the complication of pseudocyst, if we look into the most common complication of pseudocyst, will be infection and also hemorrhage inside the cyst, and the cyst can rupture. And this pseudocyst can mimic a cystic neoplasm of the pancreas. So in order to understand whether it is a cystic neoplasm of pancreas or pseudocyst, we look into the values of CEA, which is carcinoembryonic antigen values. So in case of cystic fluid, this CEA will be less than 400 nanogram per ml, whereas in cystic neoplasm, CEA values will be more. So thereby we can differentiate between the two. So in case of intervention, pseudocyst intervention, there can be two types, like external drainage and internal drainage. In case of external drainage, it is done with a pigtail catheter. So indications will be like if there is infection, there is hemorrhage inside the cyst. And before doing this external drainage, it is very important to note that we have to rule out any communication with the main pancreatic duct, because if there is a communication, then there can be a pancreatic fistula formation. That's why we will not do this external drainage, and that is why this D-Egidio classification in pseudocyst is important. And in case of internal drainage, we can go for cystogastrostomy, and this cystogastrostomy can be done open, laparoscopic, or NOTS. NOTS is natural orifice transluminal endoscopic surgery. That is like through the oral cavity, we are using an endoscope and we are reaching the stomach, and through stomach we are going to the lesser sac, and anastomosis is done. So a percutaneous transgastric cystogastrostomy can be done under imaging guidance, and a double pigtail drain placed with one end in the cyst cavity and the other end in the gastric lumen. Endoscopic drainage usually involves puncture of the cyst through the stomach or duodenal wall under endoscopic ultrasound guidance, and placement of a tube drain with one end in the cyst cavity and the other end in the gastric lumen. ERCP and placement of a pancreatic stent across the ampulla may help to drain a pseudocyst that is in communication with the gut, and surgical drainage involves internally draining the cyst in the gastric or jejunal lumen. And cystogeganostomy can also be done, like internal drainage can be either cystogastrostomy, which is done like open laparoscopic or NOTS procedure, and cystogeganostomy, which can be done like through open or laparoscopically. So the complication of pseudocyst surgery after doing the surgery, the most common complication is a hemorrhage, and infection can also take place, and also the injury to the adjacent structure. So here in this figure we can see cystogastrostomy for the pancreatic pseudocyst. So the anterior wall of the stomach has been opened and the edges drawn back, held by Babcock's forceps. An opening has been made through the posterior wall of the stomach into the pseudocyst, and the tips of the dissecting forceps are in the cavity of the pseudocyst, which is lined by slough and granulation tissue. The tip of a nasogastric tube is visible. A running stitch will next be placed along the edges of this opening, suturing the full thickness of the posterior gastric wall to the capsule of the pseudocyst. So that's all. Thank you for listening. So acute pancreatitis is one of the very important topic, and most of the questions from pancreas is asked from acute pancreatitis. So in this video, it was a very detailed and lots of information. Hope the video was useful. Please like, share and subscribe. Thank you.